pleasure to introduce our speaker, Dr. Paul Yong. Dr. Yong is a um, gynecologist at the BC Children's Hospital. He directs the research program at the BC Women's Center for Pelvic Pain and Endometriosis. Dr. Yong's clinical practice is focused on pelvic women with a particular interest in endometriosis, painful periods, sexual pain, coexisting bladder and bowel problems, and pain related to the musculoskeletal system. His clinical research interests are in endometriosis and pelvic pain, and his translational research interests include biobanking of endometriosis, gene sequencing in endometriosis, and investigating nerve formation in the pelvis as a cause of pain. Thank you for joining us today. I would like to pass my microphone to you, Dr. Yong. Thank you for coming.
Okay, I think I just turned it on. Okay. Okay, thank you so much for the opportunity to present today on clinical phenotyping of KRAS somatic mutations in endometriosis. Thank you, Yemen, for doing a land acknowledgement. I'll just repeat again that we're on the lands of the Coast Salish peoples. Also, would like to acknowledge all the co-authors on this work who are listed there. Most importantly, Natasha Orr, this is her PhD work, now graduated, and Michael Anglizio, who is the co-supervisor for Natasha and co-PI on this work. So endometriosis affects 1 in 10 individuals. It's defined as cells that resemble or that are like uterine endometrium but growing outside of the uterus. It's a common cause of infertility and pelvic pain, including painful menstrual cramps, painful sexual activity, and chronic pain. It's treated through hormonal therapy and through surgery, and accounts for about $2 billion in total annual costs to Canadian society. This is EndoAct Canada. I put the website there on the side. This is a national group that we in Vancouver are a part of. We're lobbying the government for a national action plan for endometriosis that includes awareness, the clinical aspects, and research. And you may have heard that earlier this year, one of our local MPs introduced a motion for a national action plan for endometriosis. So hopefully we'll see some movement on that in the next year or two. There are 3 anatomic subtypes of endometriosis. The first is superficial peritoneal. We use the acronym SUP. And it consists of, people see my mouse? Or is it yeah. Okay. Of superficial lesions, a classic are these pigmented spots here. But you also have to look at the atypical lesions. So these whitish lesions are also endometriosis. And then also this increase in vascular pattern are also endometriosis. And this is a part of the pelvis below the uterus. And so you'd have to remove this whole lesion if you wanted to do a complete removal of the disease. You couldn't just focus on the typical pigmented lesions. The second anatomic subtype are called ovarian endometriomas. These are ovarian cysts of endometriosis, and if you rupture them, you get this chocolate fluid here. These are destructive for the ovary. They affect ovarian reserve, and unfortunately, the surgery for these cysts can also affect the ovarian reserve and affect fertility. So it's kind of a controversial area of management, but it's another anatomic phenotype of endometriosis. And then the third type is deep infiltrating endometriosis. We'll use the acronym DIE. And this is the uterus here. This is the bladder. And then this is an invasive subtype. So this whole thing here is an invasive, what we call a nodule of deep endometriosis. And it's growing into the bladder. So it's more aggressive than the superficial type. There is a surgical staging for endometriosis, and it's based on the pattern and the amount of these anatomic subtypes. It also involves the degree of tubal ovarian adhesions for the total staging score. But if the patient had this type of endometriosis only, they would be stage 1 or stage 2. But if they had ovarian endometriomas If they had deep endometriosis nodules, like in this situation, they would be stage 3 or stage 4. So this is an endometrioma of the left ovary and the bowels pulled up because of deep endometriosis involving the bowel. So a marked anatomic distortion. So despite these different gross anatomical presentations, if you biopsy or excise all of those lesions, you see the same histological finding, which is cells which resemble uterine endometrium, endometrial epithelium, and stroma, but again, present outside of the uterus. There are several theories on how these cells get to these extrauterine locations. So probably the most favorite is retrograde menstruation, that at the time of menstruation, there's some retrograde flow of endometrium into the pelvic cavity, which is then able to attach in some instances. There's also coelomic metaplasia, that the peritoneum undergoes direct metaplasia to endometrial-like cells, and then hematologic or lymphatic dissemination from the uterus to extrauterine locations. There are also several other theories as well, but those are probably the three most discussed. Although retrograde menstruation probably the most popular, but actually I found in my experience actually some people are very opposed to that theory actually. So still a lot of controversy. So we've been trying to study somatic genomic events, particularly somatic mutations, with Mike and with David over the last decade in endometriosis. And as we've been doing this, we realized there's a couple issues that probably we didn't realize how much of a challenge they might be until we kind of have gone through the process. So the first thing is endometriosis, epithelium, and stroma form a minority of cells within the surgical sample. So if you excise this whole lesion here, most of it is actually connective tissue, fatty tissue. It's only a fraction are the actual endometrial epithelium and stroma. So it's not like and histologically as well here, this is an example where there's actually several areas, but often you look at these sections and the endometrial cells are actually quite scattered in the tissue section. So it's not like, maybe in a tumor, a cancer, where there's a lot of the cancer cells in that sample. So here they can be quite disparate in terms of where they're located. So that brings up the challenge of how do you look at only those endometriosis cells. And if you actually go back in the literature to a lot of endometriosis studies, you would take a surgical sample of endometriosis, and then they would just do like a Western blot on the whole sample. And then it's a mix of all kinds of tissues. So we've been trying to try to do some isolation of endometriosis cells from the tissue, from the surgical sample. The second is, I think Mike and I really started to realize this in the last year or two, is these patients will have multiple lesions of endometriosis. So they can have multiple subtypes. So a patient can have a deep an endometrioma, a superficial lesion, all in the same patient. And you can have multiple of each of those subtypes. So multiple deep lesions, multiple superficial lesions. And so you end up with, you could have 5, 10, sometimes 10 plus surgical samples per patient. And then that raises a question of like, do you have to study every lesion if you want to get a sense of whether somatic mutations, get a sense of what is kind of an accurate picture of somatic mutations in that patient? Or can you look at only a subset? Do you have to look at all anatomic subtypes? Can you only look at the most severe anatomic subtypes? So those are all questions that I think we're still kind of processing and trying to answer. But that's a second challenge. A third challenge is that endometriosis symptoms are very heterogeneous and multifactorial. So, for example, there's different types of pelvic pain. So the pathophysiology of dysmenorrhea may be very different from dyspareunia. So dysmenorrhea being menstrual cramps, dyspareunia being painful sexual activity. So you kind of need to look at the different types of pain symptoms, and then also each of those pain symptoms is multifactorial. So the anatomic phenotypes, the staging, has only a marginal correlation with pain and fertility. There is a partial correlation, I think, but it's not the full picture. So it's more than just the endometriosis cells. There's other factors, and it seems apparent that endometriosis seems to cause systemic changes in the body, particularly changes in the central nervous system, that modifies kind of how the patient presents in terms of pain. And so there, if you're going to look at, say, pain as a phenotype, I think you need, sufficient sample sizes. You need to account for confounders if you're going to try to correlate a molecular factor with a complex symptom. And then I would only expect a correlation, mild to moderate correlations. You're not going to see strong correlations just because it's so, the waters are so muddied in terms of all the factors that are involved. And then the fourth thing is endometriosis outcomes. So recurrence, reoperation there's complexities in the situation of endometriosis. So recurrence, a patient can present with a pain recurrence, after surgery, after an index surgery, it doesn't necessarily mean it's a lesion recurrence. And then the problem is that the lesions, only some of them can be diagnosed on examination or on imaging. So a patient can have a lesion recurrence and you're not able to tell without actually going in. So that's one area of complexity. And the other is reoperation. So for surgery for endometriosis, there's a lack of guidelines and by extension, a lack of evidence on who do you operate on and who do you not. And so the decision to operate is often very subjective. It's based on the surgeon's own practice, what the patient's own desires may be. And so while reoperation, I guess, is a hard outcome, there's a lot of subtleties into that decision to reoperate. And so if you're going to use it as an outcome, it may not necessarily reflect what one may think, or at least it's an imperfect assessment of what one may be thinking about. So it's, for example, it doesn't necessarily strongly or directly correlate with recurrence, with lesion recurrence, and it just may depend on that surgeon's individual practice. But anyway, we could talk for a long time about it, but there's not the, you have the kind of the standard progression-free survival or overall survival that you can apply in this situation. So we began this study on somatic mutations in endometriosis. The initial kind of tissue banking started about 10 years ago, and we'll talk about that later. But here, this is want to go through a review article that Mike Anglizio, Aline Talhouk, and myself wrote last year, which is kind of a survey of the literature as we been making our own contributions. So we wanted to look at all somatic genomic events. So we started with cytogenetics. At that time, we could find 16 studies for endometriosis, and there really didn't seem to be any clear, consistent, recurrent abnormalities. That probably in part is due to the different methodologies, everything from conventional cytogenetics to FISH to comparative genomic hybridization. The studies varied whether or not they isolated endometriosis cells in some way from the surgical specimen as well. We kind of said at the end, concluded that some possible abnormalities to investigate further would be chromosome 17 monosomy, which seemed to be in several studies involving FISH, and then chromosome 1 imbalances in several studies using CGH. I think it's actually would still be kind of interesting to do kind of a definitive study using modern cytogenetic techniques to get a sense of what are the, if there are any recurrent imbalances in endometriosis. The one that's kind of an exception is that there have been studies of mass forming or polyploid endometriosis. These are kind of like bulky lesions, and there have been studies showing recurrent structural chromosome aberrations resulting in rearrangement of HMGA 1 and 2, interestingly in endometriosis stroma, so not in the epithelium. So that's kind of one an exception, but in terms of other cytogenetic abnormalities, I still think it's unclear. And those structural rearrangements of that gene have been seen in mesenchymal tumors, also in endometrial polyps, as I understand. Then we moved on to early approaches to mutation detection. So there were about 20 studies we reviewed. We found in these studies, they would show low case prevalences of mutations. So typically less than 10% of cases in a paper would have a somatic mutation, probably related to limited sensitivity. These were earlier approaches using different methodologies, SSCP, loss of heterozygosity, Sanger sequencing, with or without isolation of endometriosis cells from the surgical specimen. And then in addition to these, there were a few studies using immunohistochemistry. So these were all looking at proxies for loss of ARID1A. And then these are, so I should probably have clarified, this review focused on just benign, your typical benign endometriosis. So this was not a review that was focused on endometriosis undergoing malignant transformation to ovarian cancer, which is a more specific situation. So of your typical benign endometriomas, 8 to 19% of them had IHC evidence of some somatic event in ARID1A. And then there were 7 studies on more recent approaches to mutation detection. So this included the landmark paper by Mike and David and others, 2017, where it showed KRAS hotspot mutations in a third of deep endometriosis. Some cases were done by NGS, some by ddPCR, and then they were confined to the endometriosis epithelium after laser capture microdissection. So different from the situation with the HMGA rearrangements. I'm not going to, there's much more to say about these papers. This is just going to be just an overview of a few elements. 2018, Suda et al. In Japan looked at recurrent mutations in several cancer-associated genes in 58 cases of ovarian endometriomas, and they did apply laser capture microdissection. And interestingly, one finding I'll just point out here is that they had cases where they had the endometriosis cells, but they also had uterine endometrium from those same patients. And what they found is that in these cancer-associated genes, the mutation allele frequencies were much higher in endometriosis epithelium than in the uterine endometrium of the same patient. Then another study from here, Vivian Lack, 2019, looked at incisional endometriosis. So these are cases of endometriosis in surgical incisions, most of which are iatrogenic. So after a C-section, for example, the surgical incision in the abdominal wall gets seeded by endometriosis cells, presumably. And these somatic mutations were found in about a quarter of incisional endometriosis. And then finally, not included in this review article, but Teresa Pretorius, in Mike's lab, there's multiple parts of this paper, but I would just point one thing is that 9 out of 13 patients had identical mutations across distinct lesions. So they had different anatomic lesions, but with the same mutation. And then this thereby provided evidence for clonality in endometriosis. And there was actually an editorial for this paper in Fertility and Sterility. So after this review of the literature, we just kind of thought, okay, so what does this all mean? So this is one graphic that summarizes some of our thoughts. So you have endometriosis epithelium and stroma. You have somatic driver mutations in epithelium. Is there a role of chromosome aberrations? Maybe. Or sorry, I guess specifically about numeric chromosome abnormalities here. Loss of heterozygosity, copy number changes, structural rearrangements in HMGA 1 and 2 are only in stroma. Does this then result in a change in cell proliferation and invasion, and then affect certain phenotypes? So the idea is that endometriosis, your typical endometriosis, not the subtype that undergoes transformation to ovarian cancer, but your typical endometriosis still has tumor-like qualities, even though it's benign. So it can it can grow into quite large lesions. It can be locally invasive. It can migrate to different locations of the pelvis. So if it has these tumor-like qualities, then it may be that these somatic genomic events are playing a role in its pathophysiology. And I think it's probably be easier to show a potential relationship with kind of anatomic mass effects. So, lesions that are more invasive that result in blockage of the ureter or the bowels. While, as I mentioned earlier, pain and infertility, these are more complex outcomes. It's going to be, I think, more difficult to show an association, or you will have to do kind of a deeper dive, I think, into the literature, into the data to show those type of relationships. And then we proposed a approach to studying genomic events in endometriosis. So we said step 1 should be pathology review to confirm endometriosis, epithelium, and stroma. Step 2, there has to be some sort of enrichment, whether manual or laser, to separate endometriosis cells from surrounding tissue in the surgical sample. The third, you'll be your primary methodology, whatever it might be, targeted exome sequencing, genome sequencing. And then step 4, some sort of independent validation of a somatic genomic event. Step 5, comparison to to the germline, unless it's a known somatic hotspot mutation. And then once you have a confirmed somatic genomic event, and then you want to do some sort of clinical annotation. So It could be the anatomic features of endometriosis, demographic characteristics, pain and fertility measures. We said you probably need to do some sort of correction for comorbidities for pain and fertility. Prospective follow-up of outcomes such as after surgery. We'd have to consider how many lesions you test per patient. Is there a potential relationship with mutant allele frequencies? Should we be looking at the uterine endometrium in patients with endometriosis? And then the importance of mechanistic studies as well. And if you, after this clinical annotation, and then you can see if there is a correlation between a somatic genomic event and then some aspect of clinical phenotype. So this will then move us on to Natasha's PhD project. So this project actually started 2013. Well, we started talking about it even earlier, like 2012-ish, when we started with biobanking of endometriosis samples. So it's been a long time coming. So this is a prospective longitudinal study of surgeries at the BC Women's Center for Pelvic Pain and Endometriosis, which is the tertiary referral center for BC. These are patients that underwent an index surgery between 2013 and 2017 involving some sort of surgical excision of endometriosis. So I'll just point here that surgery can be done in two ways. You can ablate lesions and destroy them using some sort of energy, or you can excise them. The issue with ablation is that you can't do it if the lesion is like on a visceral organ, like on the bowel. It's thought, I mean, the evidence is kind of a bit controversial, but it's thought that you can't really fully treat the lesions as well with ablation. And then from a research point of view, ablation, you can't get a sample for research. So at our center, we do excisional surgery. So that allows us to excise it from if it's invading into visceral organs or close to visceral organs. And then the byproduct is that we get a surgical sample that can be used for research. These patients underwent prospective biobanking through the EndoOnc study, which again started in 2012. Thank you to the UBC Gynecological Cancer Tissue Bank, who has been biobanking these samples for us right from the beginning, which was done in kind. So very thankful for that. So the patients consented for prospective biobanking, and then they also prospectively consented for our data registry at our center, which is called EPIC, Endometriosis Pelvic Pain Interdisciplinary Cohort. And then this involves clinician-reported data and patient-reported data. And the clinician-reported data is actually entered real time. So the surgical data is entered by the surgical team at the time of surgery. The charts are not reviewed later and then retrospectively entered in general, but they're done real time. The physical exam is done real time. So the data collection is very standardized and hopefully accurate. And we have data on baseline characteristics of the patients before surgery, 1 year pain scores after surgery, and then reoperation at the center up until 2022. So this was recorded in the registry. So there's 5 to 9 years of follow-up for reoperation from that original index surgery in 2013 to 2017. So then Mike and I had to think about now how many lesions do we sample per patient? There's kind of financial limitations. There's also like time limitations for Natasha's thesis. So this is ultimately what we decided upon. I'm interested in people's feedback, but we said, so if there was a deep endometriosis lesion, all the deep lesions for that patient were sampled for mutation. If there was an ovarian endometrioma, that endometrioma was sampled, plus an endometrioma on the contralateral ovary was sampled if available. So if the patient had bilateral ovarian endometrioma cysts, we would sample both. If there was a superficial lesion present, we would sample that, plus a second superficial lesion at a different anatomical location if available. Keeping in mind that there have to be sufficient tissues as well to study in addition to its presence. And then just emphasizing again that a patient could have 1, 2, or 3 anatomic subtypes. These samples all underwent pathology review and then enrichment by either manual needle macrodissection or laser capture microdissection. So the mutation assay was developed in Mike's lab. So this was a multiplex ddPCR screening assay to pre-screen samples for 6 KRAS codon 12 variants, which are listed there. And then any mutation that was found was then confirmed or validated using a variant-specific ddPCR assay. So a highly sensitive approach. So for this initial analysis, because at this point, the clinical the phenotype of these mutations wasn't known. So we just wanted to start off with just a very simple analysis, which is that we divided the patients into, was a KRAS mutation present or absent? So it was defined as present if there was at least one KRAS mutation in at least one sample assayed in a subject, and defined as absent if there was an absence of KRAS mutations in all samples assayed in the subject. You could probably analyze it in a more sophisticated way, but we're just started with this simple approach to start. The primary analysis was for anatomic phenotyping. So you actually go back to our ethics proposal from 10 plus years ago. This was what we thought. We thought, would there be an association with more severe anatomic phenotypes, particularly the deep endometriosis type and the ovarian endometriomas versus the superficial lesions? And then by extension, is there a relationship with more advanced surgical stages? The secondary analyses are all from the EPIC registry. So these are other anatomic findings, various markers of surgical difficulty, fertility variables at baseline, demographics at baseline, pain scores at baseline. And then for outcomes after surgery, we looked at pain scores reported by the patients 1 year after surgery, controlling for baseline pain scores in two ways, and then reoperation over the next 5 to 9 years at the center, and perform the Kaplan-Meier survival analysis. So there were 122 subjects in this aim of Natasha's thesis. Based on that selective sampling strategy, 262 lesions were sampled for KRAS mutations. The mean age was 34 years old, and you see the distribution of stages. So 23% were stage 1, 16% stage 2, 22% stage 3, and 35% were stage 4. So this is a Venn diagram of the lesions that the patients had. So 37 had superficial lesions only, 9 had omas only, endometriomas only, 10 had deep lesions only, 19 had superficial and endometriomas, 13 had deep and endometriomas, 16 had superficial and deep, and 18 had all three of the subtypes. Most subjects had one sample tested based on the selective sampling strategy, or 2 samples for undergoing the KRAS assay, but it ranged from 1 to 7 samples per subject. And if you did just the basic subdivision, 52.5% of subjects had at least one endometriosis sample with a KRAS mutation. So this was the mutation present group, and 47.5% of subjects had no KRAS mutations in any endometriosis sample. So we call this the mutation absent group. So the first thing we did is divide the patients into these different anatomic subtypes. So deep only, endometrioma only, superficial only, deep in endometrioma, deep in superficial, endometrioma and superficial, and all three. So this, and this, these 4 are the mixed group. And you can kind of see here, so the orange is mutation present, the blue is mutation absent. You can see that the superficial group does seem to have the lowest frequency of finding at least one mutation, while the other groups seem to be higher. So then we did the primary analysis. So these are the mutation absent, mutation present. First analysis was the anatomic subtype. Because of sample size issues, we grouped it into superficial only, patients with deep only or endometrioma only, and then patients who had mixed phenotype. You can see 35% of superficial only had a mutation, and then 60% of the other 2 groups had a mutation. Chi-square was statistically significant. And if you group deep and OMA only and mixed all together compared to superficial, then the relative risk was 1.36 for relationship of the mutation. Looking at surgical staging, stage 1, a quarter had a mutation. Then for stage 2 to stage 4, 60% had a mutation. That's statistically significant. If you group stage 2 to 4 versus stage 1, relative risk is 1.40. So this seemed to be a relationship with surgical stage. Although if you will notice there, this is probably something we need to think about more. There's not a dose response relationship with advancing stage. The 2 to 4 had a similar prevalence. Then we did then Mike and I and Natasha kind of were saying, okay, well, we kind of said, okay, there's a problem here. So because if you have stage 4 endometriosis, by definition, you have more samples. And you have more samples, you're going to be testing for mutation more frequently, and you're more likely to find a mutation. So there's an inherent bias just by the nature of the lesions. So we tried some various statistical techniques, but eventually have decided just doing a sub-analysis of those subjects who had only one sample assay for mutation, just based on the idiosyncrasies of these cases, based on a selective sampling strategy, only one sample was available for mutation. And then when we look at that subset, the KRAS mutation, the relative risk was still the same, 1.60 for association with the more severe anatomic subtypes versus superficial, and for association with stage 2 to 4 versus stage 1. So still seems like the associations exist if you only look at those samples with those patients with only one sample assayed. Again, there's going to be a more sophisticated way to look at this, but as we increase the sample size, we'll be able to look at this in different ways. And how about the secondary analyses? So where we found evidence of an association is between KRAS mutation presence and a higher risk of surgical difficulty. So what's called ureterolysis. So that is a specialized technique where you have to dissect the ureter away from the endometriosis lesion. And again, this was put real time by the surgical team at the time of surgery. So there was no bias in terms of reviewing the charts after we really knew a mutation was present. There was an increased risk of ureterolysis required if there was a KRAS mutation. And then after talking to Kate Lawrenson in California, we looked at ethnicity. And actually, KRAS mutations were associated with non-Caucasian ethnicity. So in our sample at our clinic, these are predominantly people of East and Southeast Asian ethnicity. And so the relative risk was lower for Caucasians to have a KRAS mutation, and on the flip side, higher for non-Caucasian ethnicity. So that probably warrants more study to see what's going on there. And then no other associations were observed, although for some of these secondary analyses, it was underpowered. So for fertility outcomes, I think it was underpowered. What about pain scores? So we're a pain clinic. What about pain scores? So we initially had some preliminary data suggested maybe there was a relationship with pain scores. So we looked at dysmenorrhea, dyspareunia, dyschezia, which is painful bowel movements and chronic pelvic pain, each on a 0 to 10, 11-point numeric rating scale for severity. And at the end of it, there was no associations with baseline pain scores, which is probably not surprising because, as I mentioned, the relationship between stage and pain scores is, if you just do a bivariate analysis, it's a very marginal correlation. And I think there isn't a relationship, but you have to kind of dig into the data and to look at subgroups of patients to find those relationships. But because there's so many confounders, you're not going to detect a relationship just with a bivariate analysis. And then after surgery, patients improved in their pain. So there were substantial improvements in pain. And then that improvement did not vary by mutation status, basically. So both mutation present, mutation absent had a similar improvement. What about reoperation? So there was a low rate of reoperation in the cohort overall. So these surgeries were done at a referral center, so with a high volume. Maybe a bit of a curse in this project because the rate of reoperation is 13.9% is on the low side for 5 to 9 years of follow-up. Although, as I'll mention in the discussion, what we don't have here is if patients left the referral center and then went back to their home community and got a reoperation there. I don't know how often that happens, but it's a possibility. So anyways, this is only for reoperation at our center. And then the reoperation rate was 17% of subjects with a KRAS mutation and then 10% of subjects without a KRAS mutation. A relative risk 1.66, not statistically significant, underpowered for that. The Kaplan-Meier log rank test 0.3. So this is the survival curves here. So the blue is no KRAS mutation. Red is KRAS mutation. This is reoperation-free survival. So the patients with a KRAS mutation had a lower reoperation-free survival over time, but you can see that the reoperation rate is so low over the 5 to 9 years. So in conclusion, KRAS codon 12 mutations and endometriosis were associated with more anatomically severe disease, so deep endometriomas, mixed phenotypes, higher stage. Seems to be associations with surgical difficulty, potentially with ethnicity. At this point, no relationship with pain scores, although I think if there was enough sample size, there's a chance you would find something with certain types of pain, like painful bowel movements and painful sexual activity. Maybe with larger sample size, more power, maybe we'll be able to find a statistically significant increased risk of reoperation, but time will tell. So the strengths were this was a prospective study with standardized data collection, 5 to 9 years of follow-up, highly sensitive assay with validation. Limitations is because there was a combination of macrodissection and laser capture microdissection, not the ideal situation to look at mutant allele frequency, which is what reviewers have asked for. The selective sampling strategy, so we didn't sample every lesion in the patient, and then reoperation was only assessed at the tertiary center. So what are our future goals? So for this current cohort, we, thanks to Dwayne Tucker, PhD candidate, Anna Lee, we have data on PTEN and ARID1A loss, at least on immunohistochemistry as a proxy. So that this was just finished. I can confirm this is now finished. So Dwayne is now analyzing this data. So interesting to see whether there's a relationships with any clinical phenotype or whether a combination of these somatic events. If you have PTEN loss and KRAS mutation, or do we start to see more clinical impact? So it'll be exciting to see the outcomes of that. Mike and I have funding to expand the cohort. Could be anywhere to 1,000. So all the patients, the subjects have all been recruited. Everything's collected. It's just, I think, a question of how many things like how many samples per subject are we going to assay? Because that's going to change the total number of patients in the subject. So next year, we're going to have to sit down. We have a postdoc coming. We're going to sit down and decide exactly how we're going to design this precisely. And also, fortunately, we were able to collaborate with Jillian Hanley and Aline Tahouk on this, and we'll be linking this cohort to Population Data BC. So now we will be able to look at reoperation happening anywhere in the province, or hospital visits anywhere in the province, or emergency visits anywhere in the province, and to get a better sense of kind of real life outcomes and whether these mutations have any role to play. And then finally, we don't really have funding for this, but it'd be nice to look at more genes, more mutations, do eventually genome-wide type analyses. Finally, is there any clinical application? So well, I should add a future goal. The first is to get this submitted paper published. So that's the first goal. And then the second is, is there any clinical application? Could these somatic genomic events, somatic mutations, being incorporated into a molecular classification for endometriosis? I think we hope that will be the case, but time will tell. And I think it'll be interesting to see whether we can stratify response to surgical or hormonal treatments by mutation status. So, right now, when I'm counseling a patient for surgery for pain outcomes, there's no prediction tools really. So when I counsel a patient, let's say we're going to do the surgery, I can tell you we're going to remove all visible endometriosis, but your pain outcome could be anywhere from A to Z, and I cannot predict where you're going to be from A to Z. You could have a great outcome, you could have your pain still staying the same. There's a small chance of pain getting worse. So it's I find very difficult to have that type of counseling environment. So if you can start having some sort of better classifications to be able to counsel people would be great. There is one paper already, so look at other molecular markers that found if endometriosis had a higher expression of progesterone receptor, they were more likely to respond to progestin-based hormonal therapy. So I think putting together mutations, other molecular markers, hopefully we'll be able to stratify response to treatments. And any prediction model is going to have to look at non-molecular factors as well, for sure. And then can we target these pathways affected by mutations for treatment? So a mouse model being worked on by Mike Aglizio and Anna Leonova. I would be interested to, if we could develop ectopic endometriosis organoids, like what's being done here for utopic, uterine endometrium, and then look at mutation presence or absence. So I'll be interested to talk more about that. So I'd like to thank all of you for listening, everyone in the lab, our patient research advisory board, our funding, our websites, our Twitter, and now we're talking about our new Instagram at Pelvic Pain Endo. So thank you very much.